Well, my computer says it's 7, so I'm going to go ahead and get started. Good morning. Welcome to Grand Rounds. Welcome to Tax Day. This morning, I am happy to present one of our senior residents, Dr. Rebecca Silverstein. She is originally from Kansas City, but she completed her undergraduate studies in nutrition and exercise physiology in the University of Missouri. She then went to Lincoln Memorial University in Tennessee to get her MS in biomedical sciences, as well as an MBA. While she was in Tennessee, she got her degree of osteopathy at DeBuss College of Osteopathic Medicine. She is going to be graduating this year, and as of right now, she plans to remain here to attend our clinical neurophysiology fellowship. So today she's speaking to us about the fundamentals and applications of MRI and common artifacts. Thank you.
Thank you, Dr. Mann. So we'll go ahead and get started again. Rebecca Silverstein, and just going to be talking about MRI imaging and common artifacts. So my objectives today are to describe the basic principles of MRI imaging, recognize various applications of MRI sequences to help determine diagnosis, as well as recognize common artifacts and apply fundamentals to detect those artifacts. I do not have any disclosures. So briefly, I just want to go over the history of MRI imaging. It's relatively new in the grand scheme of things. So in the 1920s and 30s, you had physicists Dr. Pauly and Dr. Rabi who discovered a way to measure magnetic properties, the spin of sodium movement, and then they developed the form of MRI imaging called nuclear magnetic resonance, so NMR. In the 1940s, the physicists Dr. Felix Bloch and Dr. Edward Purcell studied the molecular magnetic properties of solids and liquids. Their research was later used to develop MRI imaging based on water content, and they actually won the Nobel Peace Prize in Physics for their research in this property in 1952. By 1969, we had Dr. Raymond Damadian, who hypothesized that magnetic resonance could differentiate cancer cells from non-cancerous cells, and he successfully demonstrated his hypothesis with rats. And from that research, he proposed the MRI scanner in 1969 with his first patent in 1972. And he is kind of known as the grandfather of MRI imaging from all my research. In 1977, he achieved the first human MR image. It was a cross-section of his postgraduate's chest. So thankfully, someone volunteered to be the first person to do that. In the 1970s, you had chemist Paul Lottbauer, who developed new methods to reconstruct 2D images and stuck them to create three-dimensional images. And then the first MRI machine in the 1970s, just a fun tidbit, took 15 to 23 minutes to scan a little finger. And that was Sir Peter Mansfield. And since then, we have definitely come a long way in terms of the time to acquire MRI slices, now in the order of 50 to 100 milliseconds per slice. So quite improved since the 1970s. This is, again, just a timeline, just to give you a visual of the formation of MRI imaging. It has not been around too long, especially interesting that PET MRI was only in 2008. So we're still relatively new to MRI imaging. So how does an MRI machine work? We're going to talk very basics on this one. So the MRI uses the body's natural magnetic properties to produce detailed images. The hydrogen nucleus is used because of its abundance in water and fat. So when the body is placed in a strong magnetic field, the axes of the proton of that water molecule line up and create a vector along the axis of the MRI scanner. Then the MRI scanner sends a radio wave with the magnetic field, causing the hydrogen ions to resonate. You guys might remember this from physics. When the radio frequency is then turned off, the magnetic vector returns to its resting state, which causes the signal to be emitted from those hydrogen ions. And that signal is what creates the MR images. The intensity of the received signal is then plotted on a grayscale, and cross-sectional images are created. So very basic, but kind of the basic properties of how an MRI machine may work. We're going to go through some of the terminology that you use when you're talking about MRI imaging, specifically kind of the colors. So a high intensity signal is white. We describe everything as intensity for MRI. So high intensity is white, intermediate in signal intensity is more of a gray, or low signal intensity is black. And then you also have attenuation, which is a reduction in the power, or other words, suppression. So those will be some of the words that I use, and that's what they mean. So we'll go through some of the different sequences, the basics of the sequences, and how they're used clinically. So you have your T1 weighted sequences. This is pretty much part of every MRI protocol and is thought of as kind of the anatomical images. This results in images that are most closely approximate to the appearance of the actual tissues macroscopically. So for fluid, you'll usually see as a hypo-intense black color. Muscle is going to be iso-intense gray, and fat will be hyper-intense white. In the brain tissue, gray matter is gray or iso-intense, and white matter is white. So that's how you can look to see if you're unsure what kind of sequence you're looking at. That's kind of a quick and fast way for neuroradiology. Just look at the gray and white matter. And again, the purpose of a T1 weighted sequence is to review anatomy and visualize fat. So these are just some pictures of normal T1 sequences. Again, you can kind of see that gray matter is a little darker compared to the white matter. You have your CSF fluid, which is dark, and then you have it at both axial and sagittal cross section. So this is to evaluate your anatomy the best. And that arrow that you can kind of see here is pointing to the pituitary bright spot, which is also seen on T1 imaging. Our T2 weighted imaging is clinically used to evaluate a lot of different things, but specifically for like basal cisterns, the ventricular system, subdural spaces, and you can visualize flow voids within the vessels. This is one that is going to be, the fluid is going to be hyper intense, so white. Muscle is going to stay iso-intense gray, and then gray matter, light matter will kind of switch. So gray matter will be a little bit lighter in iso-intense, and white matter will be a little bit darker. You have your also something called a FLAIR image, which is our fluid attenuated inversion recovery image. That's based on the T2 weighted imaging, and that suppresses our CSF signal so we can better visualize lesions or abnormalities which are in close proximity to the CSF. This is important for like evaluating like white matter disorders, demyelination, chronic small vessel disease, and just for kind of both T2 and FLAIR weighted sequences, you can see any abnormalities usually within around 4 hours of onset. So pretty quickly to evaluate abnormalities. Again, the purpose of T2 weighted imaging is to visualize pathology, as it's usually hyper intense compared to the surrounding tissues, edema, tumors, demyelination, and complex fluid collections. So this is your T2 weighted imaging. Again, this is an axial cut. This is not the FLAIR. So you can see that now the gray matter is a little lighter compared to our white matter, which is a little darker, and our CSF is white. And so that's how you know that you're looking at a T2 weighted image. And then here on the right side is just a sagittal cut of T2 weighted imaging. And then this is our FLAIR image. So now we have that same axial cut. You suppress or attenuate that fluid in the CSF spaces, and now it's dark. And so then you are able to visualize kind of those abnormalities that may be closer to the ventricles. Specifically here, like in the middle, these are called Dawson's fingers. As some of you may recognize, this is a common sign in MS, and it's hyper intense, seen on T2. So by able to suppress that CSF signal from the T2 images, you really get a better visualization of kind of that demyelination close to the ventricle. And then again, just pointing out on the right-hand side, this is also a T2 weighted image, and this is a tumor, just showing how pathology shows up as a hyper intense. And then you can see kind of that surrounding edema as well as very hyper intense surrounding the tumor. So how do you use T2 versus FLAIR against each other? So when you would want to use both, kind of compare it against each other, is to distinguish simple versus complex fluid collections, or to help differentiate hyperintense T2 tumors. So on the upper left-hand corner here, you see this very hyperintense area kind of near the brainstem. You see some compression, and you want to know, is that fluid or is that a tumor? So you can use your T2, your FLAIR, to kind of suppress that CSF signal, and the FLAIR is on the right-hand side, and then you see now that it is black. So you were able to determine that that was a cyst formation and not a solid tumor. Versus on the bottom here, you have, again, you're on your T2 weighted image. On the right side here, you see this very hyper intense homogeneous lesion here. You might want to know, is that again a cyst or a tumor? So you use your flare to take out that water component or CSF component, and now you're able to see that this is a solid tumor component. So these are how you can use these two kind of against each other, in addition to visualizing things, abnormalities around the ventricular system. And that property, which I was just talking about in terms of the tumor, is called the flare mismatch sign. It is important in one very specific tumor, and just thought this was kind of a fun tidbit. In the case of astrocytomas, this sign, the flare mismatch sign, is very specific, up to 100% for this particular mutation, IDH mutant 1p19q co-deleted astrocytomas. It's only about 50% sensitive, but the specificity is 100% for it. So that's pretty impressive. You can use this sign to help distinguish astrocytomas from oligodendrogliomas that may demonstrate, which do not demonstrate the T2 flare mismatch. And the reason for these on a macroscopic or a microscopic level, on the left here, you can see that the tumor has a very cystic component compared to the right side, which is normal. I'm sorry, it's backwards from the pictures, but because of all these microcysts, that's where that T2 signal is picking up that fluid component. And then when you use your flare and attenuate that CSF or that fluid component, that's why you're able to better visualize that solid tumor. So I thought that was a really interesting way to use flare again compared to T2. Next, we'll talk about our diffusion weighted sequences. So there's several different sequences. What diffusion weighted sequences look for is they're assessing the ease of which water molecules move through a tissue. This will provide insight into the cellularity of the tissues, like tumors, if there's any cell swelling, like in the setting of ischemia, or any restricted collections like blood or infection. Diffusion weighted imaging is the attenuation, so suppression of the T2 signal based on how easily water molecules are able to diffuse through a particular region. So just think when you're looking at them, I'm looking at how easily water is moving through that particular area. So at baseline, for example, fluid in the CSF system diffuses easily, therefore that's the signal in the ventricles appears black. Whereas water in the parenchyma cannot move as easily due to cell membranes, and therefore the signal is somewhat attenuated, so suppressed. So just keep that in mind. We're going to go over the images, and then I'll show you what examples of these are. Another useful property of diffusion weighted sequences is you can actually distinguish the difference between vasogenic edema and cytotoxic edema. The reason for this is very important, is that you're able to potentially change management based on knowing what type of edema you may be looking at. So typical T2 imaging cannot distinguish this. It'll just show up as that hyperintense signal that we've seen previously. Vasogenic edema, just as a definition, is extracellular accumulation of fluid, usually due to disruption of the blood-brain barrier and extravasations of serum proteins. Think in, like, for example, in the setting of PRES or high blood pressure. Versus cytotoxic edema is characterized by cell swelling and intracellular accumulation of fluid, kind of in the setting of like ischemia. So on diffusion weighted sequences, you'll be able to tell the difference between vasogenic and cytotoxic edema. So cytotoxic edema is characterized by marked decreased diffusion, so it is not able to diffuse as well, whereas vasogenic edema demonstrates increased diffusion. So for example, in eclampsia, again, this would be helpful to affect management to know the difference between those two. So vasogenic, you're losing autoregulation, you have passive arterial dilation, and then extravasation of macromolecules. So maybe managing blood pressure is more important. Versus like for cytotoxic edema, if you were to see that, could be due to hypertension-induced vasoconstriction, vessel thrombosis, or infarction. So looking for other reasons for why you may be having cell death. So that's just kind of an overview. Again, I'll give you pictures of that, but we'll go into the different types of diffusion weighted or diffusion sequences. So our first one is diffusion weighted imaging, so the DWI. This is typically a low resolution image that represents a combination of actual diffusion value in the T2 signal. So this incorporates T2. The image is hypointense, isointense at baseline, and acute pathology will appear as an increased signal. So increased signal, restricted diffusion, water is not able to move through through the parenchyma or the tissue as easily. So in acute pathology, you're detecting those abnormalities and alterations in water diffusion. This is critical for use in acute ischemia, as those cell membranes are disrupted. You have water diffusion into intracellular and extracellular spaces due to the failure of the sodium-potassium ATPase pump. And these abnormalities will show up within minutes of ischemia. These are most sensitive for detecting that ischemia, but it also can be used for anything that causes restricted diffusion, like tumor, stroke, blood, and infection. With the DWI image, you have to be mindful that you can sometimes get T2 shine through, which may not represent true pathology. And basically what that means is that T2 signal, that bright fluid signal, can sometimes, quote, shine through on your image. And I'll show you a way to differentiate between a true pathology versus a T2 shine through. So that was the DWI. Now we're going to talk about our ADC. So this is representing the diffusion values without T2 effects. So these images are low resolution as well. They are grayscaled inverted DWI images. So now acute pathology will appear as hypointense, demonstrated restricted diffusion. Again, in the setting of ischemia, you have a more viscous environment, decreasing the diffusion coefficient, the ADC. Changes on the MRI, DWI, and ADC, again, are apparent within minutes, so very useful in the setting of stroke. You use your ADC image to determine if that hyperintensity that you might have seen on DWI is true pathology versus a T2 shine through. So if it is true pathology, the restricted diffusion will be dark on ADC versus in T2 shine through, the image will be bright. So again, that's another way for you to kind of look at the imaging and see if this is true pathology. So kind of keeping all of that in mind, these are normal pictures of these particular imaging. So on the left, we have our DWI image. Again, this is that T2 grayscaled image versus the ADC is our inversion of the DWI. And then oftentimes we use the flare to kind of help us age processes and to confirm diagnoses. So that's what all of these kind of look like at baseline. On DWI, remember, we're going to see hyperintensities when anytime there is a disruption causing restricted diffusion. So here on the left-hand side, you're seeing quite a large area of ischemic infarct. You're having a lot of that hyperintensity that you're seeing. On the right-hand side, you have a T1 weighted image. You see this abnormality here, and you can also use your diffusion weighted imaging to possibly confirm that this is tumor. Again, you can use this for more than just stroke. Anything that has difficulty having normal diffusion of water molecules through brain parenchyma will have changes on DWI. And then this is what I mean by the kind of the ADC correlate. So you have, you're on the left, the DWI with the hyperintensity showing restricted diffusion, which correlates again to ADC imaging, which is dark. So you know that this is true restricted diffusion and true pathology versus like a T2 shine through. So this would be in the case of a large ischemic infarct. DWI, or diffusion weighted imaging can also be used for like clinical diagnosing. This particularly in the setting of abscess formation, when evaluating abscesses, if you kind of see these particular signs, it's a very high specificity for abscess. So on the T1, you have a contrasted enhanced image, which we'll talk about. You're comparing that to B, which is a DWI. It's very bright. You have restricted diffusion, and you can also see that it's not like homogeneous. There are some areas that are less hyperintense comparatively. You're also seeing a lot of mass effect, which you can correlate to the ADC again, and you see that that is true restricted diffusion, and you can see also some of that hyperintensity on ADC, so that some of that swelling and edema, vasogenic edema, like we said, will be bright on ADC. So kind of confirming again abscess formations. This is how an example of just how it can be useful to know the difference between vasogenic and cytotoxic edema, and again, using your diffusion-weighted imaging to kind of help you with the diagnosis and therefore help you with potentially treatment. So this was a 24-year-old female. She was 38 weeks pregnant, came in with edema, systolic blood pressure of 160. At the time, we got that T2 weighted imaging here on the top left, number A, and it just shows this really hyperintense area. Remember, T2 cannot distinguish the two. Oops, I'm sorry. So really hyperintense area here in the bilateral occipital lobes. In sequence number B, you're getting your DWI sequences. So this here, the kind of larger arrows are pointing towards kind of lower intensity or hypointense, versus the smaller arrows are pointing towards more hyperintense compared to the grayscale around it. The larger areas are pointing to possibly vasogenic edema versus the arrows are pointing to cytotoxic edema. And that does correlate with our ADC. So again, the larger arrows, which are pointing to the vasogenic edema, are bright on ADC versus dark on ADC for these small areas, which are cytotoxic. So more permanent damage here for those small areas of cytotoxic edema. And that correlated here on the FLAIR imaging 3 months after, where you have these kind of larger areas here that point to loss of tissue where that cytotoxic edema was. So that was permanent damage. So again, this person had evidence of both, which may have affected their management, versus if she were just to have vasogenic edema, may have not been as urgent it would be urgent, but not as urgent as maybe some permanent damage. And then many of you have probably seen this image as well. We can also use our DWI, ADC, and our T2 images to help age processes. And this is particularly important in the processes of stroke. So like we said, our DWI, ADC, you'll see abnormalities within minutes of them occurring. And our T2 images take around 4 hours. So that is demonstrated here on the left-hand side in this image. You're in the acute process. You can already see some hyperintensities on that right-hand side on the DWI image, and they're correlating to a darkened ADC, so they correlate together, true restricted diffusion. And on the T2 image here, you may be able to see a little bit of it, but really no abnormalities on the T2 signal quite yet. Until it becomes obviously around 24 hours or 4 hours, you might start to see that T2 change. You can see also the DWI is getting brighter, ADC is getting darker. After about 7 days, you're going to have kind of changes in the DWI and ADC again, because they are inverted images of each other. So as the hyperintensity drops in the DWI image, your hyperintensity will increase in ADC. So if you were to see like kind of this brighter dark on DWI, bright on ADC, and bright on T2, you'd be able to tell that that is a chronic infarct. And again, this will affect your management, being able to age properly strokes. So a lot of you guys have seen this. This is just an example of the power of diffusion-weighted imaging. Our contrast enhanced image are typically used a gadolinium contrast enhancement, which uses the T1 signal to be increased. So you inject this contrast intravenously and you get images a few minutes later. In healthy individuals, we have an intact blood-brain barrier, so you limit the diffusion of contrast agents. However, in pathologies that disrupt the blood-brain barrier, you'll have contrast enhancement, and that's typical of what we see for like tumors and things. Pathological tissues will have uptake of the contrast due to that leakage of the cellular membranes, blood vessels, and appear brighter than the surrounding tissue. So you're looking for hyperintensities. You also have kind of fat suppression on many of these T1 images to suppress that bright signal from fat. Again, because on T1, it will be bright. So these are some pictures of some abnormalities here on the left-hand side. You're looking around the kind of the basal cisterns, the midline structures here, and you see all these hyperintensities surrounding blood vessels, and that was a indication of like a meningitis, probably like a fungal meningitis. So very bright. That's, you're pointing out abnormalities or active abnormalities. On the right-hand side here, On the left, you have a flare image, and again, you can tell because the white matter is a little darker than the gray matter, and the CSF is dark. So we know we're on a T2 flare image. You see all these hyperintensities within the tissue itself, and you want to be able to know, is this person having an active process or is this chronic? So then you get your T1 contrast enhancement, looking for if there's any disruptions in the blood-brain barrier or in those cells. And you can see that there are indeed a couple hyperintense lesions here, which are active. So the majority of them are chronic, but these ones are active, so therefore it may kind of warrant your treatment. That is how you can use contrast enhancement. Our susceptibility weighted imaging. This is an MRI sequence which is sensitive to properties which distort the local magnetic field, such as blood and calcium. And this particular imaging is actually playing on kind of an artifact of these properties and being able to use it for useful purposes. So when you think about properties like blood and calcium, they have their own magnetic field, and these compounds will distort the magnetic field and thus the signal that the MRI machine is receiving. Compounds are either described as diamagnetic or paramagnetic, and what that just basically means is diamagnetic means they have their own magnetic field, paramagnetic means they do not have as much of a magnetic field. It's most useful for identifying blood or calcium products. So when you're looking at the image, you also want to know kind of what type of sequence you're looking at. There's a lot of different susceptibility weighted imaging. You might see something called like a SWIP with a P or SWIP with an M. Kind of a rough way to understand what you're looking at. Always look at kind of the blood vessels. So every machine will have what's called a handedness, and you only can determine the handedness of the machine by looking at the SWI imaging. If you have a right hand machine, the vessels will be bright, and so therefore blood will also be bright, versus calcium will be dark. Versus if you were to have a left-handed machine, your vessels will be dark, blood will be dark, and calcium will be bright. So you don't really need to know much about that. Just if you're looking at an image, take a look at the vessels, because then you're going to it'll be helpful to you to look and see if you're actually looking at blood or calcium. Just a little play on words. This is also the type of imaging the artifact that it's playing on is what you'll see kind of also when you might have a patient with braces, or if there were to be a bullet in the brain, you could see that really dark area, and it kind of obscures the surrounding signal. And that again is because those metal products have their own magnetic field, and so therefore they do not have a signal going back to the MRI machine because they have their own magnetic field. So on the left-hand side, this is kind of a normal SWI image, or I'm sorry, a T2 image. This is of a patient who had a tumor who underwent local radiation. And you can see here on the T2 image, you see that tumor, you see kind of maybe some of that radiation site. But the power of this SWI image here on the right-hand side is that you can see all this dark area right here, all these dark spots, which if you look at the vessels kind of in the parenchyma, you see that they are dark, blood is dark, so we're looking at a right-handed system. These may represent, post-op radiation like calf mouths or just destruction to the tissue itself. So these are all blood products right here surrounding that post-radiation site. So it's pretty amazing what you can see compared to what you can't see on a T2 image or other images. You can also, again, use it to identify blood versus calcium products. So this was an example of a patient who got a CT head. I believe he had a history of like neurocysticercosis that had been treated and then came in for worsening headaches. So they were kind of trying to see, is this old infection? Is this something new? So went ahead and got a CT scan. CT scans, as you know, are very good for detecting calcium, as you can see kind of by the skull bone itself, very bright. And you see here on the left-hand side, or I'm sorry, on the right-hand side, you have some calcium or blood products, some hyperdensity in that area. And you want to be able to confirm, is that calcium, blood, or both? So they went ahead and got the SWI image here on the right-hand side at the top. Again, you can see kind of the blood vessels are dark. and you can see that this area is darker and larger than the area that was seen on the CT scan. So maybe there's more that we're not seeing, or there's both calcium and blood products. On this SWI image, again, this is a different type of SWI image. This one is, again, the arrows are pointing at the blood vessels. So you're looking at, you see there's dark blood vessels. You're looking at a right-handed system, and you can see that the blood is dark surrounding that area, but there's also hyperintensity. So that would signify calcium. So you have calcium and blood products in this area, not just one or the other. And then the T2 is just showing this as contrast enhanced area, much larger than you can kind of see on some of these other images. And this was a new onset tumor for this patient. So you see new blood vessels, calcium products, and that was how you've been able to use your SWI images again to differentiate between blood and calcium, which can be important for management. So those are just kind of some of the basics of different images, ones that we tend to use very often. So let's go into some kind of common artifacts that you can see. So MRI artifacts are common, and they also give insight into the physics behind each sequence. If you have artifacts, it also can affect the quality of the image and can sometimes be confused with pathology. So they're not benign. So when encountering MRI artifacts or something unfamiliar, it's best to determine kind of what you're looking at in a systematic way. So look at this type of sequence that was affected. You also want to evaluate the type of signal that was affected. Is it fluid or fat, for instance? Is it a hyperintense versus a low intensity? You also want to evaluate for normal anatomy outside the image field. So outside, kind of, let's say if we're looking at a neuroradiology image outside of the skull, is there something abnormal on the periphery that might explain what's going on? And you also want to evaluate for the presence of metallic foreign bodies, because again, that metal has its own magnetic field and it will disrupt signal. So therefore it might look like pathology, but it's just actually a disruption. So there's different kind of categories of artifacts. I'm going to just go over a few that I thought were interesting. In terms of hardware and room shielding artifacts, you can get something called the zipper artifact. And this is when bands of electronic noise will extend across the image. This is usually when the receiver has a disruption in the signal that it's getting. This will result in abnormal black and white signals across the image, and it will correspond to the frequency of that abnormal signal that's being picked up. So if, for instance, if you see one band, that means that there's one frequency that is disrupting the image, versus if you were to see multiple bands at multiple different frequencies, then there's a lot of different artifacts that are being displayed onto this image. So to troubleshoot this, you will make sure that the door is shut to the MRI room. Electronic devices are removed from the patient if you're able to, ensuring that the MRI machine's shielding does not have any spaces. So if there were a crack somewhere in the receiving area and it was receiving a different kind of signal, making sure that those areas are clean and fully shut. So here on this left-hand image, you just see kind of one white band going across the image. It looks like it's just one frequency, but you can see how that would disrupt the quality of the image. So this is the zipper artifact. We're also going to talk about something called the aliasing artifact, known as the wraparound artifact. It's a little hard to explain, but I'll try my best. So this is a common artifact that occurs when the field of view is smaller than the body part that's being imaged. So just kind of keep that in mind. When the area of the body that lies beyond the edge of the field of view is then projected onto the other side of the image. This is the basis of this is described as an analog to digital conversion, where the continuous MRI signal is picked up by the receiver coil and then converted into a digital counterpart. To kind of overcome this, you should have a sampling rate. So the MRI machine should be picking up those signals at least twice as high as the frequency of that signal. So at lower sampling rates, so the MRI machine is taking up signals at lower rates, the higher frequency signals sometimes become indistinguishable from lower frequency signals, and thus they become aliases. Higher frequency signals will come from the periphery of the image and then are aliased or projected over lower frequency images in the center. And I'll show you an image of this later. This will make more sense, I promise. So how to correct this is oversampling the data, turn up the amount of that frequency that the MRI machine is sampling the data. You can enlarge the field of view what you're looking at. You can use anti-aliasing software, and then again, using a surface coil to reduce noise outside the area of interest, so you're not picking up extra frequencies. So kind of a complex physics artifact, but here's a demonstration of it. So here on the left-hand side, you have a flare image here, and you see this like hyper intense abnormality on your coronal cut here in the right cerebellum. And well, that would be pretty concerning. You're wondering if there's a lesion there. But when you go to your axial cut, you don't see that particular lesion there anymore. So kind of why is that? What are you looking at here? So this is an example of the aliasing artifact. You can see here, actually, this is the patient's nose that was projected over the image in the center. So peripheral images get projected into the center of the image. And you would actually never notice this unless you looked at a sagittal cut in this particular case. So this, again, goes into the importance of looking at every sequence, every different direction that you can view to kind of evaluate these sequences, because this was only seen in the coronal cut. Axial, you weren't able to see this particular artifact, and then here in the sagittal cut, you can see that that was actually the picture of the nose. So for this case, probably the field of view was smaller than the area being observed, and therefore you got the aliasing effect. You can also have patient and physiological motion artifacts. So something called a phase encoded motion artifact. This occurs when tissue and fluid is moving through the scan. These movements are usually periodical. They produce ghost images in the phase encoded direction, and these ghost images show up as a decrease or increase of the true signal. They usually are in the direction of the short axis of the image. So when you're looking at a axial cut or coronal, this is usually from a left to right is where they'll show up. This can be seen in arterial pulsation, CSF flow, breathing, swallowing, and physical movement of the patient. So when you have these ghosts, they can be projected over normal anatomy and again mimic pathology. So the ways that you want to identify phase artifact is identify moving, flowing structures in the image and note if the artifact is in line with them. You also want to match the shape of the ghost to the structure. So if you have a moving structure and you have some kind of ghost image, the ghost should be around the same shape. So an example of a pulsatile vessel, let's say if you were on an axial cut, you should see a round ghost or a round image that looks exactly like this. And then also looking at wide windowing, making sure that anything goes beyond the normal confines of anatomy. So looking at outside the skull and seeing if there's abnormalities in that area where there should not be abnormalities. So ways to get around some of these in terms of like what you're able to do. Some obviously you can't stop CSF flow or pulsation of vessels, but you could have patient hold their breath if they're able, kind of reducing that motion. You can shorten the scan time or use immobilization or padding as needed or able. So this is an example of that particular ghost. So here on the left-hand side, you can kind of see on the left occipital lobe, kind of this hyper intense lesion here, and that would be kind of suspicious, and you might want to evaluate that further. So then you take a larger field of view, so looking outside the normal confines of anatomy, and you see actually on the periphery here, you're seeing kind of this hyper intense white spots out here in the black area, and those should not be in the black area because that's outside the normal confines of anatomy. And when you're actually able to measure it, this is actually the sagittal sinus that's being projected its ghost onto the left occipital lobe. And you can see that these are at equal intervals. So this is a ghost of that vessel here. So again, kind of an interesting way that artifacts can mimic pathology if you're not careful. So looking even outside the confines of anatomy is important. This is another one. This is a video, and I'm sorry, I forgot to move my cursor when I was in this video. We're looking at an axial cut, and we're going down, and pay attention to kind of the midline structure here. You see these like kind of hyper intense areas here in like the basal ganglia, thalmi area, which was kind of abnormal, and it kind of looked chunky, as you will say. On the right-hand side, it should start here too. We're looking at a coronal cut. And again, you kind of will see these hyper intense, not normal looking areas in the, in kind of the deep structures of the brain. And it'll go back through it one more time. Right there. So you see those hyper intense areas and you're like, wow, is that pathology? What's going on? I'll stop here in a second. So this is another example of that phase encoded motion artifact. So here on the left-hand side, this is a still of that axial. You see these hyperintensities and just like a very abnormal looking deep structures. And you see it here again on that coronal, kind of these hyperintensities. But now you can better appreciate that this is in line with something, right? So here you have the vessels down here, which are hyperintense, and this is kind of like a line. And I don't know a lot of pathologies that cause lines like that. And this is actually a ghost of the internal carotid, which is being projected into the brain parenchyma. So this is also, again, highlighting how important it is to evaluate the structures that are being, that are moving in that area, as well as looking at different sequences. I'm sorry, did I miss a chat? Oh, we're good. So again, looking at different views as well, because that, without looking at the kind of the coronal and the sagittal cuts in line with that vessel, you may not be able to appreciate that linear ghost that was present, and it's on both sides in line with the ICAs. So I thought that was a really cool mimic of pathology. You can also have intraventricular CSF pulsation artifact. This is something that we're very commonly often seen. So CSF pulsation artifact can produce a diagnostic problem, especially on FLAIR images, resulting in what might appear as intraventricular pathology. This is common in patients who are young with small ventricular sizes and images that may be captured at lower magnetic field strength. So sometimes, you know, not here, but at outside hospitals, even here it can be seen. But if you have a lower magnetic field strength, you may be able to see this pulsation artifact. This artifact is not seen on T1 weighted images. So again, this is highlighting the importance of looking at all your sequences when you obtain an MRI. So here on the left-hand side, we have our T1 image. You're looking inside the ventricle system. Looks fine, it's black, you don't see anything. But how come on this FLAIR image, now you're seeing these hyperintensities, and you may be concerned that that's pathology, but really that's just CSF motion artifact. So that would be important to correlate with your T1 image, knowing that you can have this artifact specifically on your FLAIR images, and correlating to know what you're looking at, that is not pathology. It also can be seen in the spinal cord here. On this one, you're kind of seeing this dark spots that the arrows are pointing to, and that again is just CSF flow void. Dr. Kuwabara, I was trying to get some words of wisdom, and he said it's just something you have to know and look out for, so be mindful of that. The Gibbs artifact, also known as the truncation artifact, is another interesting one, and this is very physics detailed, and Dr. Kuwabara, again, who helped me with this project, said that most neuroradiologists don't even know how to explain this one, but I'll try my best here. So this artifact is a series of lines in the MRI image parallel to that MRI location that you're looking at, to abrupt and intense changes in the object or anatomy at certain locations. Examples of that would be at the CSF spinal cord junction and at the skull base interface. You may have this artifact. When there is an abrupt change in signal intensity, the results of imprecise representation of the interface and tissues in that area. So the computer gets a little, or the MRI machine gets a little confused when there's abrupt changes. These artifacts can be minimized by reducing the field of view or increasing the phase direction, but can never be totally eliminated. Things to know about this one, it's not seen on axial slices. And again, it's probably because the field of view is much smaller compared to like in a sagittal cut, which I'll show you these examples of the Gibbs artifact. Gibbs artifact specifically at the like CSF spinal cord junction can sometimes mimic syrinx, and so that's why it's important to know what this is so that you're not diagnosing someone with pathology that doesn't exist. So here on the sagittal MRI, we have a T2 image. You can tell we're looking at a T2 image again because that CSF is bright, spinal cord is darker, and the arrows are pointing to this very like light, hyper intense signal that's all the way through the cord. And so that would be kind of concerning. And so you would want to correlate it also with your axial cuts. This is again another image of the same thing, hyper intense CSF, kind of a hyper intensity throughout the center of the cord. If you were to look on axial cuts, however, this would not be present. And so this would actually, this is a kind of like, again, a ghost image or Gibbs artifact of that CSF fluid that's being projected onto the spinal cord itself. And you can tell, again, that this is common in sagittal cuts because your field of view is very large. You're getting spinal cord, bone, the whole kind of area versus like when you have an axial cut, you have kind of a larger image of the spinal cord compared to the sagittal cut. So that's why you would want to lower your field of view. So if you are concerned about this, of course, look at your axial cuts. If you don't see that hyper intensity through the center of the cord, you can likely think that this is Gibbs artifact. And in the words of Dr. Kuwabara, again, you just kind of have to know what it is and what to look for to know that you're not looking at pathology. This is another example of it on T1 sagittal. You can see here we're looking at a T1 because the CSF fluid is dark compared to the cord, and you have a dark or hypo-intense signal running through the center of the cord. Again, you can also lower the field of view or increase the power. So they increase the power on this image, and now that that artifact is mostly gone. So that's how one way to get rid of it. Again, same thing here on the right-hand side. Sagittal, you see the hypo-intense lesion through the center versus when you increase the power, it's now gone. And again, you will not see these on axial cuts because of the way the field of view looks. And so just kind of looking at this between a syrinx and this artifact, a syrinx tends to be more sharply defined, more hyper intense. It is evident on both T1 and T2 imaging. And you'll also see that on the axial imaging. So an interesting artifact that can be confused with pathology as well. So always important to look at multiple views, multiple different angles. I think that's all of my artifacts. Here's my references that I used for this talk. And I just want to give a special thanks to Dr. Kuwabara and Dr. Mangum, who put a lot of time and effort into this project with me. And thank you. Does anyone have any questions?
That was very well done. Thank you. Just a quick question. Can any post-processing remove some of these artifacts, or once they're there, they're there?
Usually once they're there, unless you fix it in the MRI suite itself, is what Dr. Kuwabara was telling me. Some of them you can use like the aliasing effect. You can have anti-aliasing software that can take it out, but often you have to troubleshoot these problems while the scanner is being, while the image is being processed. Thank you, Dr. Bhatia.
Another question for me. Are there any sequences that are most susceptible to artifacts, or is it just sort of each artifact can affect different sequences different ways, and there doesn't seem to be one that's...
No, yeah, from my understanding, there doesn't seem to be one that's more susceptible to artifacts. It's more, I think, from my understanding, it's more like the field of view. So like kind of what you're looking at, if it's axial versus coronal versus sagittal, and kind of those interfaces, how much of the image you're actually looking at is my understanding. I don't think there was anyone that was particularly more susceptible.
Thank you. Again, well done.
Thank you. Any other questions? All right. Thank you, guys.
Thank you for being with us today and sharing your presentation.
Thank you.
Have a great rest of your day.
You too.
Okay.